Afternoon, everybody. We are here for Corrugated by Design, a webinar exploring how next-generation aspiration technology is redefining first-pass success in stroke. We're joined today by Dr. David Fiorella from Stony Brook and Dr. Sunil Sheth from UT Health Houston. David's going to talk to us first about Corrugated by Design. Dave, take it away.
Yeah, great. Thanks so much, Tarun. I really appreciate it. I'm just going to share my screen, which should be sharing now. I'm going to get off camera and I will go into presenter mode. Everybody sees that okay?
Yeah, we can see it.
Great. So I'm going to talk a little bit about the family of catheters and delivery systems made available by Perfuse. They're a little bit different than our current catheters used for aspiration thrombectomy, and we've incorporated them into our lab, and we use them quite avidly today. We do a little bit more than 200 thrombectomies a year here at Stony Brook. I'm a consultant for Perfuse and multiple other industry sponsors, as you can see here, and the principal investigator for several trials, including 2 that are involved directly with acute ischemic stroke. So in 2026, and our setup has evolved quite a bit over time, and that's why I say 2026 current thrombectomy setup at Stony Brook, because as the various sponsors that we have come up with better and newer products, I'm always very eager to try them and incorporate them into our system of care to see if they improve our ability to do thrombectomies in these patients. So currently we, if we're going femoral, we'll use a 9 French femoral sheath. If we're going radial, we use that short 8 French radial corridor. We use a Capel Walrus balloon guiding catheter for all cases, which locks me into the Millipede88 device. I typically don't use the 088 catheters, but I know many people do and have had great success with them. We will use the Zipline delivery assist device with the Millipede70, or if it looks like we may have to go after something a little bit more distal, we'll use the Socrates 38 within the Millipede70. We use an 088 Aristotle wire to deliver the Millipede Zipline combination, and we use the Colossus micro wire if we're doing the Millipede Socrates combination. So this is our setup for all stroke cases. The way that our lab works is my techs and nurses will have all these devices prepared in the bowl that while I'm driving in for the case or walking down to the lab for the case. So it's very standardized for all anterior circulation stroke. So why did we incorporate Millipede into our practice? Well, 2 reasons. First is ease of navigation, and then efficiency of aspiration, and particularly first pass effect. This a lot of times is talked about primarily with the 088 catheters, but I think because of the construct of the 070 catheters, they're also best in class currently for efficiency of aspiration in addition to ease of navigation. So when we talk about first pass effect, why is this important? Why is it important to be efficient with thrombectomy and get the clot out the first time with good revascularization if possible? Well, there have been multiple studies that have looked at first pass effect, and more data are accumulating every day. But in general, we know that clinical outcomes are better if you can achieve first pass reperfusion. That also translates to shorter lengths of stay for the patients because they're better functionally after the procedures, and also because we're able to remove the clot with fewer use of ancillary devices. That leads to lower procedural costs for the patient. And this has all been demonstrated in various studies looking at the importance of first pass effect. So moving on to the Millipede aspiration system, it's a combination of a catheter and an introducer catheter. And when you look just at the graphic depiction of the catheter here, it's obvious that the distal part of the catheter is a little bit different than what we're used to seeing. So when we look at the Millipede aspiration catheter, it has a unique corrugated design. So the Millipede70 has the corrugations internally. The Millipede88 has the corrugations externally. And so these corrugations allow the catheter to be quite a bit more flexible than typically designed microcatheters and larger catheters used for aspiration. The internal catheter, the Zipline catheter, is this inner catheter that acts as an introducer that removes the ledge effect as we're navigating these aspiration catheters up into the head. And this is compatible with the 018 micro wire. So first, with regard to the corrugated design, what you can see here is that the catheter easily takes a 180-degree bend at its distal aspect, making it more navigable and also maintaining the luminal diameter despite even marked tortuosity intracranially or proximally in the distal cervical segment. Then more proximally, the catheter starts looking a little bit more like a standard catheter with a coiled transition zone, allowing for some flexibility in the cervical ICA. And then even more proximally, a typical braided design that gives it excellent support for good pushability. The catheter is made out of an EPTFE liner, which is a little bit different than the typical PTFE liners that we're using. And so when we look at scanning electron microscopy of this, you can see that the EPTFE looks a little bit more like a sponge, and the PTFE looks a little bit more like a homogeneous surface, like a painted wall. And this translates to a tremendous difference in flexibility. So the EPTFE has much more flexibility and resilience. And so this acts much more like rubber, whereas the PTFE behaves a little bit more like cardboard. It's a little bit more stiff. And so this EPTFE allows the catheters to be very flexible and conformable in tortuous anatomy and resists kinking, where the PTFE oftentimes will kink when placed through tortuous anatomy. And so these two things work together synergistically for delivery and also to maintain the luminal diameter to improve the efficiency during aspiration. And so when we look at a conventional catheter, you can see here in this model where we have sort of a spring attached to a fixed surface, it has a very difficult time navigating over that spring. However, with the corrugated design, you can see it quite easily navigates over this. And this is translated clinically into much easier distal navigation of these types of catheters due to this unique corrugated design and EPTFE composition distally. When we look at the Millipede88, again, as I mentioned, the corrugations are internally rather than externally. So when you're using this catheter on the table, when you look at it, you actually won't notice the corrugations because they're inside of the catheter, but it still has this EPTFE liner. And regardless of whether these corrugations are internal or external, this type of microfabrication results in the increased flexibility. And so actually the FDA recognized this by providing them with the FDA breakthrough designation because of these unique design capabilities that differentiate the Millipede system from all other available aspiration catheters. With regard to the larger catheter, we know that there's a significant increase in aspiration force by catheter internal diameter because force equals the difference in pressure times the cross-sectional area of the catheter. And so there's a relatively linear increase in the ability to create aspiration force depending on the cross-sectional area of the catheter, which increases by the internal diameter. And so when we look at this and the importance of the Millipede design to maintaining that luminal diameter, which is so important to differences in flow and the ability to aspirate, it's demonstrated very well here in comparison to other catheters. And so what they did is a really unique experiment where they place in a very slow and suspense building manner several ball bearings of different sizes ranging from 0.084 to 0.088. And then when they aspirate these through the corrugated design catheter, you can see that they all easily pass through the catheter. However, if we take a standard catheter with a 0.088 lumen, so same size lumen on the bench, and then we place these same ball bearings into the model, you can see when we aspirate the same dimension of ball bearings, they don't all fit through the catheter. In fact, they catch up in the catheter. You can see here which ones go through. So hold on, we'll load them on the typical commercially available 088 catheter that is not corrugated. And when we suck these through, only the 084 goes into the catheter and becomes lodged at that point of tortuosity. And so the unique corrugated design resists this ovalization around curves where the typical PTFE catheters with a coil design distally do not. And so this maintenance of the luminal diameter in areas of very high tortuosity is something that's very important to aspiration because you can imagine a thrombus would be stuck here in some cases where it would pass through a corrugated 088 catheter. And so this is also visualized when you cast the internal portion of the catheter and then see what that looks like. And so if we cast the inside of a millipede with luminal casting, you can see that it maintains this 088 diameter pretty much throughout, even in the areas of highest tortuosity. However, if we look at a competitor, a typical 088 catheter, which you can see here is in the area of maximal tortuosity, there's enough kinking whereby you lose a significant portion of the internal diameter. It goes from 0.088 to 0.078. So a substantial reduction in the internal diameter in areas of high tortuosity. And so because the Millipede88 and the Millipede70 maintain the integrity of the internal lumen because of this fabricated corrugated design, they're incredibly efficient in regards to the ability to aspirate large clots out of the head. The Zipline access catheters are just designed to allow these larger catheters, the 070 and the 088, to be seamlessly delivered into the intracranial circulation. And I'll show a couple examples of cases. And so this is really what it's about. I'll show a couple of cases with the Millipede. And so this is just a typical right M1 occlusion like we wind up in every day. We do the aspiration, and I started to look at, these are all cases that I got over the past 6 to 8 weeks. So I just went back in the system and looked at our cases over the past 6 to 8 weeks. And so this case, when we looked at the total fluoro time for the case was 8 minutes. So one pass, TK3 flow with very good distal revascularization. This is the second case, 70-year-old patient, terrible aortic arch, typical M1 occlusion. And so this is just the 018 microwire going up. You can see the Zipline easily traverses this anatomy. And then you can just watch the 070 catheter travel through this. And again, this anatomy is not particularly challenging, relatively straightforward, but you can see how quickly and easily we can get the 070 catheter over the Zipline into the M1 thrombus. We can then hook it up to aspiration and do aspiration thrombectomy. And this entire case, total fluoro time, 14.5 minutes with TK3 revascularization. Here's a third case, NIH stroke scale 16. It's a typical left M1 occlusion. Now, this is a little bit more of a difficult case. So you can see here, there's two 180-degree switchbacks in the distal cervical internal carotid artery. And the patient also had a very challenging left-sided backwards facing aortic arch, as we encounter not infrequently in these types of cases. And so you can see here, I'm starting the case. My first picture, run number 1, is at 1:18 p.m. And this is the navigation of the Zipline around this tortuous anatomy, then followed by the corrugated 070 catheter. So you can see the Zipline follows over the Aristotle 18 wire, no problems, into the region of the thrombus. And then we're easily able to get the 070 catheter up. And then we're going to nudge the Capel balloon guiding catheter over the 070 catheter after it gets up a little ways to get a little bit more support to navigate through all of these areas of tortuous anatomy. And eventually you'll see the balloon guide catheter come up too on the back tail of this as we start getting into the M1 segment. And so you can see we're very carefully advancing the 070 catheter over the Zipline. And we've approximated all the outer curves of these vessels. We've gotten the balloon guide catheter to follow over the curves. Who would have ever thought we'd have a balloon guide catheter that could do stuff like this, but we do now with the Capel balloon guiding catheter. And then we're able to direct that 070 millipede catheter just into the proximal aspect of the thrombus. We then inflate the balloon, attach to aspiration, and pull this out. And you can see here that in a total fluoroscopic time of 7.6 minutes, we're able to get this clot out. So you recall the first image from the case was at 1:19 or something like that. And the last image from the case is at 1:22. So 7.6 minutes of biplane fluoro time and a total first image, last image case time of about 4 minutes. This is case 3, NIH stroke scale 14, 65-year-old. So nearly occlusive thrombus in the proximal M1 segment, but there is a little bit of flow around it into these opercular branches. So again, this is the kind of situation where we just want to kiss the clot. We don't want to ram through the clot or fractionate it into multiple pieces. And it's like a saddle. There's some in the upper and lower division branches. So in some in the anterior temporal or lower division M2 branch and the upper branch. And you also note here proximally, again, 180-degree double switchback. And so we would like to, typically in a situation like this, get our Zipline catheter or whatever guiding wire we're using, or internal catheter way out to provide support to get across all these switchbacks. But we can't do that here because we're looking to avoid disrupting the thrombus. And you can see here just how tight this 360-degree curve is on the lateral. And so again, what you'll see here is that Zipline delivery catheter over the support 18 Aristotle wire makes this pretty easy to navigate. And so again, you recall the tortuosity proximally cervically. And so we're going to go slow here with the Zipline, just get it slightly over the top of the catheter with a 180-degree turn in the wire, a J shape on the wire, and then very carefully navigate up that 070 catheter just to the very face of the thrombus. And then we're going to do our aspiration thrombectomy. And with a total fluoro time of 8 minutes, we're able to aspirate out this clot and restore perfusion to that right hemisphere. Tiny amount of in situ residual thrombus there that we're going to treat with just some intraarterial TPA, and the patient does well. So case 4, similar. This is a distal M1 occlusion right at the M1-2 junction. You can see the anterior temporal branch is open, accounting for this area of flow on the B plane. We're going to navigate up over our Zipline catheter into the distal M1, and you can just see how easily that 070 catheter goes over that rail of the Zipline. It's just absolutely seamless and easy to guide this through anatomy, especially if the anatomy is non-challenging. Just absolutely easy to get the catheter exactly where you want it to get. I did have to go after something distal here, so the total fluoro time was 31.7 minutes, but you can see the level of revascularization that we got here. there's a little M3 clot that we had to get out with the Socrates at the end of the case, but you can see we've got perfect TK3 reperfusion and 31 minutes of biplane fluoro time for this case. And then here's the actual angiographic runs of the case demonstrating the level of revascularization. I always think it's good to show the real time and the laterals to show the revascularization here. Case 5, again, this is a carotid terminus occlusion, a little bit more of a obnoxiously hard clot. And again, here, 180-degree double switchback turn in the distal cervical carotid. And so again, we'll cross into the clot with a J-shaped configuration and navigate up the Zipline catheter into just the very proximal clot and then through the clot. And then over this, we're going to take the 070 catheter. And you can see how easily this navigates around this turn. And this turn goes way, way down inferiorly. So you can see the catheter disappears off the screen, then shows back up on the screen, and then easily goes over the zip line into the mid portion of this thrombus. We're able to grab onto the thrombus and pull it out. And again, combined A-plane, B-plane fluoro time, 8.1 minutes to achieve TK3 revascularization. And you can see here that switchback loop in the carotid. So this is just the lateral picture, just depicting the revascularization. I think this is really helpful to tell the type of flow that we've got from these cases. Then case 7, I think this is the last case. So again, carotid terminus clot, very, very hard to get through. You can see here, I'm struggling with the microwire, bouncing off of it. It's going to find the PCOM, which is the last open branch. It forms a J at the clot. I'm looking like I'm having a little bit of difficulty. And then I just start to get engaged. That's going to the PCOM again. You'll see here, eventually, I just get engaged into the front part of the clot. And so once I get engaged in the front part of the clot, one of the things we found with the Zipline is the tip is very, very atraumatic. And so if you can find a little channel or get engaged in a little channel, oftentimes you can just advance the Zipline over the microwire, and the Zipline by itself will kind of find a little channel through the clot. And so you'll pull back the wire and then gently put the Zipline forward. And it's so soft and so atraumatic that it'll kind of fish its way through the thrombus. And then this again provides you with a nice rail to work over. And I think that this probably is even more atraumatic than probing with the wire, the tip of the wire, because it's a little bit bigger diameter and you're just very gently pushing with it and it's so soft. And so then this acts as an excellent rail to get the 70 catheter over the top of it. And then we'll attach that to aspiration and get revascularization. Again, this is 12.6 minutes of combined A-plane, B-plane fluoro time with beautiful TK3 revascularization. And so these are just the actual angiographic pictures from that showing our revascularization. So in general, the reason we've sort of moved over to the perfuse system for our dominant 070 aspiration catheter is because of just this. With the Zipline and the corrugated distal design and EPTFE, it does seem like the delivery of these catheters is even more seamless than the excellent aspiration catheters that preceded it. The thrombectomy appears to be more efficient. And I think these microfabricated design catheters, these corrugated catheters, are really going to be a significant improvement in our ability to do thrombectomy for that reason of maintenance of the integrity of the lumen at multiple points of serial tortuosity. So instead of having numerous fingers on the hose throughout every turn that you have to use to approximate to advance the catheters distally, we have really no limitation of the lumen at these areas of high tortuosity. And so the lumen is maintained patent and full throughout the entire length of the catheter. And so I think this type of advanced design of the distal aspect of the catheters are going to be really important, and even more important as we incorporate these types of designs into things that are, say, going to change our pressure waves. So the variable type of modulated aspiration that are going to be coming soon to our space, I think will be maximized. The efficiency of these will be even greater maximized by these catheter designs. And I think for distal thrombectomy, as we get smaller catheters that have these designs, because we're going to be working through even more anatomy and more tortuous systems, that for the distal thrombectomy, this is going to be even more impactful as we get smaller catheters with these types of microfabricated and advanced design. So I think this does improve my efficiency for thrombectomy. It makes my thrombectomies better, I think. It makes them faster, and it makes the reperfusions a little bit better. So that's really all that I have, and I'm happy to turn it back over to the other presenters for any questions.
Thanks, Dave. Those are some fantastic cases. We have a question from the audience for you. The question reads, how often do you need the anchor technique to get the 070 up from the Millipede family?
Yeah, using the Zipline, I don't do that typically, or I haven't really done that, I've been able to pretty easily manipulate these catheters into the intracranial circulation. Again, I'm not using the 088 catheter. Those don't fit through the balloon guide. So I am kind of a strong believer in balloon guide technology, especially for distal aspiration and these types of things. So we use predominantly the 70 catheter. I can't say that I was having a ton of failure delivering the 70 catheters before, but it's just easier with this. And so the number of times I'd need to do any other maneuvers is really, really greatly limited by the technology that's been provided with us. And I find that as the years go on, it just becomes easier and simpler to do these cases. And again, very grateful for all the new technology that we've been provided with.
Thanks, Dave. Let's turn over to Sunil.
Okay, great. Thank you, Tarun and Dave. Awesome presentation. Really enjoyed it. I'm Sunil Sheth. I'm a vascular interventionalist here at UT Health. And I'll be talking mostly focusing on 088 aspiration, kind of building from what Dave had on 070. And I wanted to emphasize one of his points, or in general, the comments that he made. I learned a lot from his presentation. And I think this idea of really understanding your catheter design cannot be overemphasized. It's very easy to sort of pick something out of a box and then use it because the rep has come by and told you it's great. And we really have to understand our devices and the engineering that goes into them. The reality is that we ask so much of our catheters, right? We want them to have maximum ID, we want them to have minimum OD, so they have to be very thin-walled, but we also want them to navigate. We also want them to withstand high vacuum pressures and not ovalize through tortuosity. And understanding how your catheter works is going to be really pivotal for your patients. The reality is every catheter has its strengths and weaknesses, and understanding that will help you a lot. I remember when I was a fellow at UCLA, Gary Duckweiler, who's incredibly accomplished interventional neuroradiologist, would take every new catheter that was given to him, and he'd put a Kelly clamp on the distal end, and then he'd attach a Luer lock syringe to the proximal end, and then inject as hard as he could with saline just to see where the catheter would break. And of course, the rep's face would blanch when he started doing this. But I think this understanding of what all has gone into your catheter and what his tolerances are is super important. So that was great in terms of what Dave was presenting, and especially that ball bearing example where we have this idea of ovalization, but the reality is we're so blind when we do thrombectomy because we don't see the clot. We don't know if we've captured it. We don't know if we fragmented it until we do the run afterwards. And seeing that benchtop testing with the ball bearings is so interesting. So I will be talking about the 088 and focusing on the data that was generated from the Mars clinical trial. We do a little over 300 thrombectomies here in Houston, but more relevant is we were participants in the Mars clinical trial, and then since that trial, we enjoyed the catheter so much we've been using them routinely in our clinical life. So first, my disclosures, most relevant here again is that I am a consultant for Perfuse and on the scientific advisory board, but I'm just as biased with every other company. So you can ignore everything I say or understand that I'm equally biased by everyone. So Mars was their FDA IDE trial. It was a prospective, independently adjudicated single-arm study. There were 235 patients enrolled across 22 sites and a large number, over 50 physicians. And again, all the endpoints were independently adjudicated. The inclusion criteria were pretty standard, but some key points are that this was both anterior and posterior circulation, all within 8 hours. Again, we're looking FDA on label stuff. For ICA, M1, M2 occlusions, and the posterior circulation, basilar and vertebral artery. One of the unique aspects of this study was the FDA did require vessel diameter measurements for the use of the 88 or the 70 catheter. This was a new thing. I don't know if any other trials had this requirement, but this was the case for the Mars trial. And again, as I was saying, this was an open label because it's a single arm interventional study, but it was independently adjudicated in terms of all the endpoints. And again, the size requirement was a new thing for this study. In Mars, there was no Zipline yet. So this was the typical setup for a Mars patient. Was the 88 catheter here, as you can see with its ribbing, the corrugation, as Dave nicely described. That was navigated over a 70, a Millipede 70. So that was the system, was 88 over 70, and that was because, again, for the trial, there was no Zipline yet. Since the trial, we have locally transitioned to using the Zipline for all of our 70 and 88 cases, as Dave showed. Same thing. So this is a little diagram of the subjects that were enrolled. So 235 were enrolled, 55 were removed as pre-screen failures or angiographic screen failures. By and large, these were patients who had, let's say, an M1 occlusion or M2 occlusion on CT angiogram. About half the patients in the trial got TNK, and then they came for angiography, and now it's an M3. Or it was a basilar occlusion, now it's a P1 or P2 occlusion. So most of these were screen failures because of distalization of the thrombus. Again, this is early time window trial. Over half of them got TNK, and so this is not unexpected. Then there was an intention to treat population for what was remaining. And then there was a per protocol, so a few patients were dropped out for the per protocol analysis. But for this presentation, I will show you mostly intention to treat data, so the kind of full, unfiltered, transparent numbers, no gaming the results here. And of those 142 per protocol patients, over half were 88 aspiration, and of those, most were M1 occlusions. One of the points, I think the main point that I want to make here is that 88 aspiration, in a certain way, it's like a natural progression from our other aspiration catheters. We started off back in the day with 3 max in this kind of 040 range, then we got to 050-ish range, and then 060, ACE catheters, and then we got to 070, and there was a sort of natural progression from the 040s to the 070s. But 88 aspiration feels to me like a different category. For the FDA, it definitely feels like a different category because the rules are different to the regulation. But this concept of 88 aspiration feels new, and the point that I want to make with it during this talk is that 88 aspiration is meant for the M1. It's not like necessarily the case where you have a big IC terminus clot and it comes down to the cervical segment. Oh, now I'll use the 88. 88s really work in the M1, and that's one of the main points I'd like to get across. So here's the breakdown of this intention to treat population. Again, the full population that was analyzed, about half were women, kind of typical, but pretty high stroke scales, median was 17. Again, over half got thrombectomy, and then the vast majority of patients were IC and M1. Of those, most of them were M1. Again, this is pretty typical distribution of most device thrombectomy trials. Right, so the main results, this was a study in which the primary outcome was reperfusion rates. And so 89%, almost 90% of the cohort got substantial reperfusion, defined as sticky 2B or greater, with the definition endpoint of within 3 passes of the Millipede system. So that is the primary outcome, is sticky 2B within 3 passes, and almost 90% got there. End of procedure sticky 2B, so if there were adjunctive therapies that were provided, 98%, so essentially almost the entire cohort. And then again, safety is kind of the key metric when you're thinking about 88 aspiration in terms of adoption. 2.3% sympathetic hemorrhage rate, very, very, very comparable, good, acceptable for this field of any type of thrombectomy system. Okay, but I want to focus on 88, and with Millipede88 in all comers, again, this is the all patients who got 88 catheters, 60% first pass effect across all vessels, and then in the M1 population, first pass effect defined as sticky 2C3, not 2B3. We're talking about real good reperfusion, 75%. This is a number we have not seen otherwise in any other trial, in any other rigorously conducted clinical study, with 96% delivery success. So this 75% number, to me, represents a substantial step function, a real quantum change in our FPE. So if you look at first pass effect across most, I would say, well done prospective studies over the years, it's really hovered in that mid 50s, mid 50%. And, you know, kind of smaller studies will show higher percentages, but in terms of like rigorously conducted prospective, independently adjudicated, core lab adjudicated studies, it's usually in the 50s, maybe mid to high 50s. 75% is a substantial leap up, and this is honestly what has convinced me to use this system. Is I like data, I like numbers, and this was a very important result to me in my practice. So why should we use Millipede88 in M1s? The reality is, and this was a very nice paper that was published, is that Millipede88 is vessel matched in terms of OD to the M1 segment in the vast majority of patients. Some patients it's going to be a little bit too small, a little bit too big, and some patients are actually going to be a little bit too small. In Texas, we get some big blood vessels, and I've definitely been in the case where the Millipede88 is still too small for an M1. But in the majority of patients, the Millipede88 is matched to the M1 diameter. Vessel matching is really important when you're thinking about aspiration. We'll get to that in a second as well. It is safe. These safety numbers shown here at the bottom of the screen. Again, this is based on the intention to treat population, so all comers, no cherry picking. These are the numbers, you know, extremely acceptable. In fact, mortality numbers were quite low compared to other studies, but I would say very, very, very acceptable safety profile for these 88 catheters. And then again, the proof's in the pudding. 75% first pass TICI. The what is this? I don't know. Purple color is the 88 catheter. First pass effect 75%, substantially better than the 70. And the reason being is vessel matching. If you look at 2B or more, you know, then the numbers go up 82%. But like Dave was emphasizing in his talk too, we really want our goal, our gold standard, you know, what we should be aiming for is this 2C3 on the first pass, and 88 and then M1 will get you that 75% of the time. There's a lot of talk about learning curve with 88 aspiration, and I think it's a very justified discussion. These do feel like different systems. The catheters look very similar, and I think that if you use Zipline, I'm going to show a case here in a minute, they're going to look indistinguishable from Dave's cases because it's a Zipline and a Millipede catheter. Mine just happens to be 88. But there is still a little bit, at least mental block to get over in terms of using these catheters. And in the Mars study, you know, there was no quantifiable difference between people who did it a lot and people who did not do it as much in terms of enrollments. I mean, I will say, you know, the other kind of interesting point with the Mars data is that for, I think, everyone in the study, it certainly was for me, these were my first Millipede cases. I wasn't someone who'd been using these catheters for a long time because they just come out. And despite the fact that I hadn't really used them before, you know, we got very good results. Our local results were slightly better than 75%, and that's why they have me giving this talk. But you know, our local results were actually a little bit higher than that. We had very, very good experience, and that is why we've adopted the system here locally. Is that we, you know, the proof is in the pudding, and we, in our hands, whatever reason, our patient population or the way we do things, it seemed to work even better. So we had no issue with learning curve in the study. There was also no issue with that, which again kind of speaks to the easy translatability of these devices. These are two little videos that I'll show. Again, just sort of emphasizing that 88 does a great job with clot ingestion. This is a Sophia Plus, so an 070 type catheter versus an 88. And the 88 actually here is not vessel matched. You know, it's actually kind of small for the vessel, but there's more aspiration power, and it does a nice job with the clot. I think Dave's video with the ball bearings is probably more impressive, but either way. Okay, so why does vessel matching matter? I think this graphic gives a very nice illustration of that. Even with an 070 in an M1, a typical M1, you are not occlusive. This is why, you know, people like balloon guide catheters, this idea of flow arrest. But with an 070, you get very mild flow reduction in the M1, and then even when you turn on aspiration, there's still flow because you're not occlusive, you know, ultimately at the origin. And this is illustrated here. Whereas if you now use an 88 catheter in the M1 and you are vessel matched, now you actually get flow reversal. But you have to have that vessel matching to get the real flow reduction in the distal vessels, and then to actually get distal flow reversal, so that if there are little bits and pieces that break off, it's going into your catheter, it's not going to fly distally. I think this was a very nice data-driven reasoning behind why vessel matching is important. Published in JNIS. Okay, so I will show one case. I always like to be thoughtful about showing cases in these presentations. I decided to, instead of kind of cherry pick a case, I picked my most recent 88 Zipline case. And you know, it's not perfect, it is what it is, but it is my most recent one. Actually, it's not my most recent one, it's my most recent one when my slides were due. So this was a couple weeks ago. But either way, this was my relatively most recent Zipline 88 case. This 38-year-old woman with a left IC terminus occlusion. She has a very high stroke scale. Her aspects are fine, and she got TNK. Now you might say, okay, Sunil, you're presenting a young lady, so of course there's going to be no issues navigating your 88. But there actually is some tortuosity with, as you'll see, and also young women may have very small M1, so you could make the other argument that 88 may not fit. But you'll see here that there's really no issue. So here's our first run. I use a Cook shuttle for my 88 cases. It's an 8 French system. So I put in a short 8 French sheath, then I exchange that over a Benson guide wire for this Cook shuttle and the introducer. We get a lot of questions on closure and, you know, is it safe, this kind of thing. But it's the same 8 French angioseal. Actually, I prefer Perclose for my 8 French closures. It's the same. It's an 8 French. You can close an 8 French sheath. You can close an 8 French Cook shuttle. It's essentially the same thing. But as you can see here, there's some tortuosity in the cervical carotid, and then the contrast goes up, and on the lateral it goes kind of just past the ophthalmic. So nice little just post-ophthalmic IC terminus occlusion. We did our first pass. Sorry, I didn't save the fluoro for the first pass, but here's the run after the first pass, and we don't get first pass ticky 2C3. It happens, especially with IC terminus occlusions. Again, I'm not cherry picking cases. I'm just trying to show you what we got. And I think one of the points that I'll try to make is 88 aspiration. So the first pass was Zipline over 88. 88 works great, but to me, it's ideally optimized for the M1. So we do an ICA terminus pass. The catheter on the first pass didn't go all the way to the M1. It stayed, you know, in the ICA. We got a chunk of it out. Now the PCOM is open, but there's still clot sitting in the terminus. And so for my subsequent pass, which I did have to save the fluoro for, at least the part of the pass. So we have our Zipline coming up over our. This is just a 14 wire. I use the Aristotle 14, but 18 makes a lot of sense to me. I pull the wire back so the Zipline's kind of straightened, and then I have that springy bit actually going just over the IC terminus into the M1. The 88, you know, just like Dave showed, takes that little turn in the carotid, no problem. Goes in the M1, no problem. And then I like to be in this M1 vessel matched segment where the 88 is going to be flow arresty. It's going to be pulling in distal emboli that might come out. And then we get our nice Tiki 3 results. So 2 passes, IC terminus occlusion, same exact system. But again, I think one of the points I want to make is that the 88 is optimized, in my view, for that M1. And you get reperfusion rates, 75%, we haven't really seen before. So with that, I will wrap up. Also happy to answer any questions and take any comments. Thank you so much.
Neil, I think those are great points about vessel matching. You know, I totally agree with you. I think the 88 is indeed designed for the M1, and the more often we can deliver it up there, much smoother the cases go. I too have some cases where we sort of get the carotids open as a first pass, and then once it goes into the M1, you know, that's where it really shines. So let's see, there's a couple of questions that have come up, and
let me turn off my screen.
Here's an interesting one. What's the practical difference that the Zipline makes when you're crossing the ophthalmic?
So I guess the question is, does it prevent the catheter from getting stuck on the ophthalmic?
Stuck. Yeah.
Yeah. I mean, I guess, yeah. So each of these just like with other catheter systems, there are zip lines for each Millipede system. So the Millipede 070 system has its 070 matched zip line, and then the Millipede 88 system has its 088 matched zip line. And then the ledge between the zip line and its matched catheter is minimal and very, very small. So I have found that if you get, you saw on the fluoroscopic views, there's that spring within the zip line. Like Dave was saying, that tip is very soft and atraumatic, so it's not a problem really to navigate that into the clot. And then I found that when that springy bit is over the part wherever you're worried about the ledge, whether that's the ophthalmic or the M1 origin, there's minimal ledge effect there, and it seems to navigate very smoothly.
Yeah, another question. As our experience has grown from Millipede alone to Millipede and Zipline, and we're seeing first pass effect more consistently, can we get a perspective on cost savings? And obviously it does turn into reduced use of stent retriever, but I'm wondering if any of you have cost related pressures like all of us do where we work, and how has this system sort of impacted that?
Sure, I'll go first. Yeah, so in the Millipede trial, of course, there was no cost because everything was free as part of the trial, which is great. Everyone loved that. But the system was essentially two aspiration catheters. It was a 70 and an 88. Those are priced differently than a delivery catheter and an 88 and an aspiration catheter. So I don't know the numbers off the top of my head, but Zipline plus Millipede is, I'm sure, cheaper than two Millipedes combined. The other thing I'll say is that for my 88 systems, I use the Cook Shuttle. Cook Shuttle is dirt cheap. So that's one of the things that people, like. I know that the company is making their own guide catheter, I'm sure, but cost-wise, everyone has different contracts with vendors, but the Millipede system is very cost-effective for us.
Yeah, I would agree with that. Is the shuttle has sort of really dropped the cost down on the guide for us too, and our stent retriever usage has sort of gone through the floor. I mean, like really in the low single digits. So, go ahead, Dave. You're going to say something.
Yeah, I totally agree. I think if you're not using stent retrievers, or if it reduces the need for stent retrievers, whether you're using it for anchoring to get catheters up there, or if you're using it for the actual thrombectomy, I think that saves a lot of money. But nothing saves more money than having good patient outcomes and getting patients out of the hospital earlier. So I think if it is augmenting your first pass effect, and especially TQ2C3 first pass effect, and I think that's something that's really important to appreciate about the data that you guys got in the Mars trial, is that that's a different first pass effect than what we're usually used to seeing being reported in the literature. The benchmark for first pass effect has been TQ2B or greater in almost all cases, and even those numbers are pretty low in the 40 or 50% range. What has been reported in the Mars trial, and I think this is the first trial that's done so, we're talking about TQ2C and TQ3, so perfect or near perfect revascularization first pass. And I think that's something that uniquely differentiates the Mars trial and the performance of these catheters from other trials. And I think the greatest cost savings that we can achieve comes at the benefit of getting our patients good outcomes and getting them out of the hospital earlier. So a couple $100 more for a catheter, if it's going to help one or two people have better outcomes, I think that's going to more than pay for itself for your lab and for your hospital system.
Well said, David. Sunil, next one's for you. Is the Mars data enough to tell us we need to make the switch to 088 if the vessel is big enough? And do you still measure vessels now that we're no longer in the trial?
Yeah, great question. If I'm being totally honest, I may not have been the best measurer even during the trial. But I think the reality is that we're all pretty good at eyeballing things these days. We look at so many CTAs, and I usually make the decision before we do an angiogram. So, in my personal view, the answer is yes. I think that if I can use an 88 catheter, that is going to be choice number one for my stroke. There are some situations where we don't want to use an 88. I want to use balloon guide. There's a tandem occlusion. There are some situations where I don't. It's more distal, that kind of thing. But for me, if there is a ICT or M1, I love going for an 88 catheter first. But as Dave showed, not all 88 catheters are the same. So this is where I think it's very important to understand what you have in your hands, what its weaknesses are, what its strengths are, and what's going to work well for you. So the short answer is yes, I think so, my view.
Okay. Another question, and this is a toss-up. What percentage of cases would you say the Millipede88 is vessel match for the M1, since the outer diameter of the catheter is about 2.74 millimeters? I guess this one's primarily for you, Sunil, given the 088 usage.
Yeah. As I was saying, I have never really measured my vessels, certainly since the trial. And I think if, the vessel looks like a reasonable size, and these end up being honestly smaller than that, I definitely post facto I'll measure and it's like 2.5, or it's like 2.6, something like this. It's certainly less than 2.7. It has never been a problem. These vessels are compliant. The catheter is very soft. You're navigating with a system that has minimal ledge effect. So the likelihood of dissection is very, very, very small. So I don't check to make sure it's greater than 2.74. In fact, frequently it is less than 2.74, and that has been totally fine for me.
Yeah, I mean, I think if you look at any of the roadmaps that you've seen in your history of your doing thrombectomies when you're doing stent retrieval, and the amount of distortion that you create of the native anatomy, I think worrying about a catheter that's like 0.25 millimeters larger than the diameter of the vessel, especially if delivered over a Zipline and there's no ledge there at all, is probably not as significant as the trauma caused by doing a standard stent retrieval case in the M1.
Yeah, that's exactly right. It looks like we're almost at the end of our hour. Any closing comments, gentlemen?
No, I think this was great, and thanks so much for your contribution with the Mars trial. That's really great data, and you did a spectacular job of getting them for your patients and for the forward movement of the field. Thank you so much.
Oh yeah, no, I wasn't the PI, but I was happy to enroll. But yeah, no, I think it is. I think it is wonderful data. I mean, the thing is, like, I think in our field, and just speaking generally, one is I think we do need to demand, like you were saying, Dave, very eloquently, FPE, TICI2C3. That is really what we need to be pushing for. And I think this is an area that has to be rigorous with the data. It's so easy to sort of say, look, I got great results. But we have, in my view, languished in this mid-50s range when you, like I was saying, when you do it in that rigorous fashion. And, what is that next step that gets us 80%, 90%? How do we get to that? And I think this, to me, is that first indication that, like, this 88 system is a real change. We've had so many improvements in our aspiration catheters up to the 070, 072, maybe 074, but nothing that's clearly shown like a substantial difference until now. And, how do we iterate from here? 88 plus something else. You mentioned the modular aspiration. Who knows? 88 plus, TNK. Who knows? There's I think a bunch of new areas to explore, but it really opens the door now. So on the research side, on the kind of what's next side of things, it's very exciting, because I think now we have something that has shown us we have a real conduit towards a quantifiable, major, statistically significant improvement in what business as usual has been.
Yeah, no, I look at that too, kind of at the flip side of the coin, because I remember years ago doing these thrombectomy cases with things like Mercy, and you were talking about reperfusion at the end of the case. So you've thrown the kitchen sink at it, and if you could get that number to 50 or 60%, you were super happy. And then all of a sudden, we got so many great devices that followed after that, from stent retrievers to aspiration catheters. Then it was like, what is your revascularization at the end of use of your first index device, whether you had to do 3 or 4 or 5 passes? And now those numbers are all in the high 90% range. So now we've even iterated further to what is your first pass effect. And I would just argue back. I mean, you remember, Tarun, in our early days at the Cleveland Clinic, we weren't even worried about first pass effect. We were just worried about, can you possibly get the vessel open before everybody's speakers are completely wrecked who are in the room? And
I will go one step backwards, even say, I think we were concerned about, can we actually get from the femoral artery to the M1?
Right. Yeah.
And I think what at least Perfuse has done is, if you take a look at 98, 99%, like, we're getting up there with Millipede, right? And of all the times we're getting up there, 3 out of 4 times the vessels are getting open on the first try. Right?
Yeah.
That is a huge, huge leap from where we were.
Yeah, definitely. And that's the great thing about being in this field, is that every couple of years we get stuff that just makes things so much easier and better for the patients. And so it's really such a great privilege to practice in this field at this time with guys like you who are moving the field forward with real clinical science and prospective data. But thank you so much.
Yeah, no, we're spoiled for riches with these. And I will also just say one more thing, especially for the trainees in the field. This is one of the real reasons to work with industry, is to get the opportunity to iterate and improve things. You know, this feedback and partnering with them and kind of practicing in real time, taking these catheters and trying to destroy them and then giving them the feedback so you can make improvements on them. This is how the field moves forward. You know, it's honestly not through anything else besides that kind of work. And we're very, very fortunate. There's been so much investment into this area and commitment from industry. So it's a good thing.
Yeah.
All right. I think that wraps us up for this evening. Thanks, everybody.
Yeah. Thanks so much. You guys take care.